My name is Julie Barron. I'm actually the International Medical Director for Exact Science in Geneva, and it's a real pleasure to welcome you tonight. One more word from me before I hand over to Dr. Hartkopf, and towards the end we will discuss patient cases. If you have a patient case, a particular one in mind, please prepare that in the back of your mind, and we will hopefully be able to address your questions at the end of the session. So with this, Professor Hartkopf, I would like for you to basically take the lead and share with us your experience. We don't hear you so far. You are on mute.
Now I have unmuted my phone. So
okay,
thank you, Julie, for this introduction. I'm a medical doctor, gynecologist from Tübingen in Germany. And I want to share with you some experience we have with the oncotype, and I want to share you my my personal view why we use it in which situation we should use it. There's something painting on my slides. Someone is painting on my slides. Can you see this? It's not from me.
All right, we'll take care of that.
Okay, that's great. Okay. What you can see here is a very large meta-analysis from the early breast cancer trial Collaborate group that was published in 2012 in The Lancet. And what they did is they pooled patient data from different chemotherapy trials, and the aim was to compare chemotherapy versus no chemotherapy, but also what kind of chemotherapy, anthracycline-based chemotherapy versus not, taxane-based chemotherapy versus not. And this is actually one of the results they show. It's the question, how do chemotherapy actually benefit, or patients that are treated with chemotherapy are actually have a benefit versus patients that do not receive chemotherapy. And what you can see a significant difference. However, one problem, and that's something that is not that is not displayed by the slides very well. In the clinical practice, you can see this difference if you look at the overall population. But the problem is that most of these patients are still overtreated if you use chemotherapy. So this benefit is driven by some patients that do benefit from chemotherapy, while a large amount of these patients will not benefit from chemotherapy. And that's the problem we have in the clinic. We use chemotherapy in breast cancer, in early breast cancer, but it's difficult to identify those patients that actually benefit from it. And please show the next slide. And the next thing, and I was very astonished when I see those results, is they were looking at some tumor characteristics and patient characteristics to see whether they could identify a subgroup that will benefit from chemotherapy. And it's actually it's the wrong. It's because it's anthracycline and versus non-anthracycline. I'm sorry, there is another chart in this analysis where they show chemotherapy versus not. And but actually it looks the same. So I can tell you it looks the same. It's just the difference is one of the other analyses they did, it's chemotherapy versus not chemotherapy. And actually the slide looks the same. So what they cannot define any subgroup that will have a large benefit from chemotherapy, or any subgroup that do not have a benefit from chemotherapy. So the thing, what we do in clinical practice, we look at the prognosis. And even though the prognosis is very different in these patients regarding ER status, grading, age, menopausal status, the benefit those patients derive from chemotherapy is always the same. So when you have patients with a good prognosis, the benefit in the absolute benefit is very small. The relative benefit in all those subgroups is always the same. And that's why we use chemotherapy in patients with a bad prognosis, but we do not have any tools or any classic tool to predict the efficacy of chemotherapy. And that is what is the difference between a predictive and a prognostic biomarker. A prognostic biomarker shows us who needs therapy, even though it's chemotherapy or not. A prognostic marker shows us the prognosis without a treatment and tells us who will need any kind of therapy, whereas a predictive marker will tell us how effective a given treatment is. And you can use prognosis to indicate treatment too, but the thing is, if you use prognosis, the relative benefit is always the same. The only thing that changes in the populations is the absolute benefit. And that's why genomic risk scores are used more and more in the clinic. And the Oncotype DX is one of those risk scores. And for me, it's the one where we have the best data, the best evidence. And it's actually based on 21 genes and that mostly deal with proliferation. And the result of the Oncotype DX gives you a score which range from 0 to 100. And I will tell you we will talk about the ranges when to use chemotherapy or not later on, so we can skip this right now. Can you show the next slide? So one of the initial data we have seen from the recurrence score was a retrospective prognostic analysis. A retrospective analysis where a prospective trial was used, and the data or the samples, the tumor samples they have collected in this trial were analyzed by using the Oncotype. And the thing, what was done in this paper on this analysis is that the hypothesis, so the question whether recurrence score can divide patients that will benefit from chemotherapy and patients that will not, the question was the hypothesis was given, and then they did the analysis. So even though they used samples from a clinical trial that had been done in the past, so a retrospective analysis, it was a prospective. The question that was asked for, so whether the recurrence score will identify patients that benefit from chemotherapy, was asked prospectively. And for me, I think this is a good way to validate or to develop prognostic and predictive biomarkers. And what you can see here is only in the patient subgroup that have a high recurrence score, ranging from 31 to 100, they do actually benefit from chemotherapy. And all those other patients with a low recurrence score or a mid-range recurrence score that do not benefit from chemotherapy. And those what was done in patients that were node negative. That is important if we see the next for the next slides. Then what you should always do if you have a biomarker, and even though if you had a good validation study, you should always do a prospective trial and not only validate it prospectively in a retrospective retrospective analysis. And that was what's done in the TAILOR-X trial. It's a phase 3 trial where patients were randomized to receive chemotherapy depending on the recurrence score subgroup. So the patients with a low recurrence score, they were treated with endocrine therapy alone, and patients with high recurrence score, and that's what we have learned from these other analyses, they were treated with chemotherapy. And those patients with a mid-range recurrence score were randomized in chemotherapy or endocrine therapy. And if you can see here, the ranges from the recurrence score, they were a bit different, so a bit more conservative, but actually, I think that is something, yeah, I think those ranges, it's something what actually reflects what we do in the clinical, even before we had seen those results of TAILOR-X. And inclusion criteria, of course, hormonal receptor positive, HER2 negative, because triple negative and HER2 positive patients, they will always receive chemotherapy, and the tumor size was larger than 1 centimeter or high grade, and then the tumors could be a little bit smaller. Like, okay, so the next slide, please. And the first thing, what you always have to look at if you do a prospective trial is how does this trial reflects what you can see, the biomarker you already know. And you can see here the tumor size, and in the blue graphs, and the patients in light blue and in dark blue, those were the patients with small or big tumors, and in the x-axis you can see the different recurrence score ranges. And yeah, to make it short, it's you do not see any different differences with regard to the different ranges of the recurrence score and different tumor sizes. And when it comes to grading, there is a difference. So patients that have a high tumor grade have a higher risk of having a high recurrence score. However, even in patients with a higher grading, grade 3, about 50% of the patients still have an intermediate or low recurrence score. And that's something what's very important. But in the clinical practice, the patients with high grade are actually those patients that would receive chemotherapy. And it means that in this group, in the patients with high grade tumors, you can spare chemotherapy by about 50% of the patient. And when it comes to clinical risk, that's when you combine grading and tumor size, you can see the same picture. Patients with the high clinical risks, they do have higher values when it comes to the recurrence score, but even in those patients, about 50% of the patients with a high clinical risk have a low recurrence score. And then the next slide. And I think this is something that we will see later on. You have always compared the results of a clinical trial with what you see in clinical reality. And in this paper, the SEER database was analyzed and compared to the results seen by the TELEX trial, and the distribution of age, tumor size, tumor grade, and also the distributions of the different recurrence scores, they were the same. So the TELEX does actually reflect clinical reality. And the next slide, please. And those are the results in the intermediate group. So that was the group where patients were randomized to receive chemotherapy or endocrine therapy only, and you can see no difference. So the curves are absolutely identically. And the next slide, and this was invasive disease-free survival, and the secondary endpoints were distant recurrence-free survival and overall survival. And here you see the same, no difference with respect to those endpoints. In this slide, you can see the different groups, and actually there are 4 curves, but you might only see 2, because the thing is 3 of those curves, they are the same again, and the only patients that do have a worse or a prognosis are those patients that had a high recurrence score, and the prognosis was worse or not as good as in the other groups, even though those patients received chemotherapy. And in the blue and yellow graph, you can see there's no difference. So to summarize what we have seen, those patients with a low recurrence score and those patients with an intermediate recurrence score, they do not benefit from chemotherapy. And patients with a high recurrence score, higher than 26, they have a chemotherapy benefit by 6% at least. And next slide, please. But then is very important to see if this is actually independent from the clinical features of the tumor. So I showed you a few slides ago that the recurrence score correlates with grading and clinical risks. However, the predictive value when it comes to predict efficacy of chemotherapy is completely independent from those clinical features. And that is why we can use the recurrence score even in those patients. Next slide. So that's what I told you when we had see those bars a few slides ago. If you treat patients without using a recurrence score or a genomic assay, then you usually use clinical risks. And if you just use clinical risk without recurrence score, then you would overtreat about 70% of the patient. And if you use low, if you see at the group with patients with low clinical risks, then 43 patients of the patients had been undertreated, because in the low clinical risk group there are indeed patients that have a high recurrence score. So this is what you can see in this slide. I have the impression that when I talk to some colleagues, that they use recurrence score only in patients with a low clinical risk, because they want to know if they should use chemotherapy. But one important thing is, I think you should use the recurrence score also in patients with a high clinical risk. But because if you do not do it, you will overtreat a large amount of patients. And the next slide, please. There was in San Antonio, I think it was 2 years ago or 1 year ago. Actually, I lost some time. It was 1 year ago, I think. There was a subgroup analysis where age was a factor for the interpretation of the different recurrence score range. And the recurrence score range, I told you, they are mostly for patients that are older than 50 years. Those are the patients where you should use a recurrence score range from 26 to 100 when it comes to chemotherapy use. And in patients that are younger than 50 years, the ranges are a little bit different. There is good data that patients with a lower recurrence score, that means from 21 to or higher than 21, also have a benefit from chemotherapy. And even those patients with a recurrence score ranging from 60 to 20 have a benefit from chemotherapy. However, this benefit is not very high. So what we do in clinical practice, and I think it's also in the recommendations of the AGO, which is the German board that does the recommendations to treat patients, how to treat breast cancer patients every year. I think in those slides, it's also, they say patients that are younger than 50, you should use chemotherapy if the recurrence score is higher than, or at least 21. And that's how we do it in the clinic. And in patients that are older than 50, we use the cutoff of 26. Then I had the chance to receive data from all patients that where Oncotype DX was performed in the clinical routine, so outside of clinical trials in Germany. And I had a data set with about 4,600 patients. And we could look for recurrence score and correlate it with clinical data. And the only thing we did not have is outcome data, but we were able to correlate the recurrence score with those data we could see in the pathological report. And the first analysis we did is to look if the distribution in the real life in Germany is the same as it is in the other publications in TeleX or in the CR registry. And this distribution, where most of the patients have a low recurrence score, a recurrence score lower than 26, is also seen in the clinical practice in Germany. And it was 84% of the patients, they had a recurrence score lower than 26. And those patients do not need chemotherapy. And I won't say that you would have spared chemotherapy in 84% of the patients, because there are, of course, many patients where you might have not used chemotherapy by using clinical predictors or factors. However, the number tells you that there is a large amount of patients that will not need chemotherapy in this group. And then what we did is we compare clinical factors with the recurrence score, and we could do something that was not part of the TAILOR-X and what is very interesting, I think. And we could look at nodal state and Ki-67 because, as you remember, in TAILOR-X, only node positive patients were included, and we had no information on Ki-67. And one thing which is very important, the nodal state does not impact the recurrence score. This is important. You can see a slightly lower amount of patients with a high recurrence score in node positive patients, but I think that is a selection bias because it was not a prospective trial, it was a retrospective analysis of data that we received from patients where Oncotype was performed in Germany. And I think the thing is that in node positive patients, I think the clinicians will use the Oncotype DX even if they have a low grade G1 or G2 tumor. And in node negative patients, I think they do use, or they did in this analysis, the Oncotype was more used in patients that were at higher grade, and that's why you can see a difference in the node positive and node negative patients, with is actually contradictory. So a lower amount of high recurrence score in node positive and a higher amount of high recurrence score in node negative patients. But what you can see is that seems to be a correlation with Ki-67. However, it is not that big. And maybe we can see the next slide. I think this is where all those dots are. Can you have the next slide? Yeah, what we did is we looked at, we did an analysis how the recurrence score and the Ki-67 match together, and on the x-axis you can see the recurrence score results, and on the y-axis the Ki-67, and each dot represents a patient. And blue would be the patients where recurrence score and Ki-67 are concordant. So you have a low recurrence score and a low Ki-67, or a high recurrence score and a high Ki-67. And red are those patients where you have disconcordant results. So where the recurrence score is not reflected by Ki-67. And those were about 50% of the patients. So 50% of the patients would have been treated not the same if you use Ki-67 instead of the recurrence score. And this is something I think which is important. And I think Mark will show you some slides where the problems of the Ki-67s are. The first thing is that it's not standardized. And the second thing, we do not have any prospective trials that use Ki-67 to predict chemotherapy. So if I see those disconcordant results, and we do have prospective data for Oncotype DX, I would rather use Oncotype DX rather than the Ki-67. So to conclude, Oncotype DX will identify patients that do not benefit from chemotherapy in clinical high risk group. Oncotype DX will identify patients that do not benefit from chemotherapy in the Ki-67 high group, and using the Oncotype score results to guide chemotherapy decisions can spare patients from unnecessary overtreatment and risk of undertreatment. Thank you.
Thank you, Professor Hartkopf. I think we'll keep the questions for the end, because there's a lot of synergy and interesting discussions to have together with the lecture from Professor Thill. So Professor Thill, welcome. And you will share with us your experience in the REMAR real-world evidence study and show us how optimizing treatment or how you have optimized treatment decisions with multigene testing and Oncotype DX in particular. Thank you.
Yeah, thank you for the introduction, and thanks to Professor Hartkopf to give the introduction for our two issues we want to present, his data and our REMAR study data. My name is Mark Thill. As said before, I'm heading a Department of Gynecology and Gynecological Oncology in Frankfurt, Germany. And we had this idea of the REMAR trial within our Rhine-Main area. So these are my disclosures. Next one, please. Yes, there it is. And we had this idea on basis of national and international study results. Our idea was to design a prospective, non-interventional, multi-center and non-randomized study to show the clinical relevance and to assess the clinical relevance of the Oncotype DX in combination and in the end in dis or concordance with the proliferation marker Ki67. And we wanted to show that in daily routine in a predefined prospective patient population with exclusion and inclusion criteria, we'll talk later on, with an immediate risk along the classical clinical pathological parameters. And it was done in our Rhine-Main area. So this is an area consisting of nearly 6 million people in Germany, in the middle of Germany, surrounding Frankfurt. Next, please. The REMAR design was presented several times. So we did some poster presentations in San Antonio. And the last one was this year at the European Breast Cancer Conference, unfortunately virtual. But as you can see, the inclusion criteria, patients were very easy. So patients with an age lower than, higher than 18, tumor stage 1 up to 3, node negativity or nodal positivity up to 3 positive lymph nodes, tumor grade 1 and 3, ER positive, of course, HER2 negative, of course, and Ki67 range was 10 up to 40%, and then, of course, no distant metastasis. The study design and the workflow was as follows. So we had the first multidisciplinary team meeting. We decided to go for an oncotype and then for participation in the REMAR trial. The treatment decision was documented without Oncotype DX. You know that from the decision-making studies. What would you do without Oncotype? And then we had the first discussion of the MDT results with the patient. So we went in the first discussion with the patient. Then we had a questionnaire before Oncotype for the physician and patient, and later on, of course, after. The patient had to sign informed consent for Oncotype DX test and for the participation in the REMAR trial. And what we wanted to have was central testing of Ki67 and grading, but this didn't influence the treatment decision. The treatment decision by each center was done via the local Ki67 and local grading. And then Oncotype DX was done within the REMAR trial. Then we had the second, one slide back, please. And we had the second MDT after receipt of recurrence score results, and then the second discussion with the patient, and then the questionnaire after the Oncotype DX results for physician and patient, and the treatment decision, and of course there was the final questionnaire for the physician. So something that was really, let's say, time consuming, but I think in the end it was worth to go for it for all the talks with the patient MDT meetings. Next, please. To give you maybe a better idea, what is this Rhine-Main area all about? You see the different red spots. So it's really an area. So it's consisting of different hospitals, of course. In Germany, we have quite a few hospitals, more than 2,000 hospitals in whole Germany. But this was directly from one area. And as you can see, so different breast centers, what I would say the most important breast centers in our area participated in the trial. We recruited more than 600 patients, and in the end, eligible for analysis were 587 patients. And this was a funny thing, was 1% of the inhabitants of our Rhine-Main metropolitan area. Next, please. Regarding the methods, again, the inclusion criteria on the left, and then the study duration from September 2016 to February 2019. And we wanted to have an adjuvant therapy recommendations based on histopathological and clinical data, of course, and then in connection with the recurrence score result followed by the German guidelines. And Ki-67 tumor grade, as I said, were determined twice locally, plus separately and independently a second time. And as I said, the central testing didn't influence the treatment decision. Next, please. Regarding patients' characteristics, so well, first we thought maybe there is a bias to register the patients maybe with a lower risk, maybe with a lower intermediate risk. But as we can see, 30% of our patients were node positive. So this is real world in the end, 70% node negative, 30% node positive. The mean age was 57 years, the median age was 57 years, and then you see tumor type, most of them, of course, non-specific subtypes, more than 80%. Then we had some lobular cancers and some others. Tumor size mean was 22.3 millimeter and median size 19 millimeter. And then you see the tumor stage. And to conclude this, there is another box on the right side. So T1A, below 1%, T1B 10%, 1C 45 to 40% T2, and some of the patients had a T3 stage. So I would say for the tumor size, so not that really low risk patient population. Next, please. So more patient characteristic regarding grade, and then you see central and local, you see the differences. Not really in grade 1 or grade 2, but in the end, when you compare that with grade 3, then we had in the central testing a lower rate of grade 3 patients, 4% grade 3, and in the local grade testing 16%. And regarding the Ki-67, there was a difference regarding the median Ki-67 central of 8.1% and in the local 20%. And this is something we will find later on when we talk about the trial results. Regarding the recurrence score results, we had a mean result of 18 and a median of 17. And regarding the pre-Taylor and post-Taylor X recurrence score groups, you see that we have 80% in the lower and intermediate risk and 19% in the higher risk with a recurrence score of 26 up to 100. Next, please. So what is this? And Professor Hartkopf already showed you the clinical context of the Taylor X data with the SEER registry data. So what we wanted to show you was the clinical context or the consistency of the recurrence score result distribution in comparison to the Taylor X study. And as you can see, we have really consistency regarding the recurrence score result distribution in REMAR compared with the Taylor X study. Next, please. And yeah, now we added our REMAR trial results to the slides that Professor Hartkopf had shown already, to the Taylor X and to the SEER data. Regarding the age, we really hadn't had a precise age distribution, but we had a median age of 57 years, ranging from 29 to 83 years. So this is, as you can see, in the mid. So this is what I would say really good representative. And regarding the tumor size and regarding tumor grade, I think this is quite nice to see that we have bigger tumors than in Taylor X, bigger tumors than in SEER, and we have a tumor grade 3 that is comparable in the end to the Taylor X data and the SEER data. Next, please. Our goal, one of our objective and primary objective, of course, was the change in treatment recommendations after recurrence score results. And when we thought of the idea of making this registry, we wanted to have consistent results of an area in Germany, as I said. We wanted to have a clinical utility to present to the payers, to the healthcare providers. So this is something that worked because in the end, not only because of the REMAR study, of course, but the oncotypes is reimbursed in Germany. And meanwhile, so this is really something as a part of the whole success we had in Germany. And as you can see, the patients who had an initial recommendation for an endocrine treatment only on the left side, they changed to endocrine or to chemoendocrine treatment by 19%, so not that much. And on the right side, you see the initial recommendation for an endocrine and chemotherapy treatment. And this is really important because 65 of the patients switched from a chemo indication to a pure endocrine treatment alone. So this is something that is really substantial advantage for our patients by avoiding chemotherapy. And all in all, the treatment recommendation changed by 33.5%. Next, please. If you are interested in pre to post testing overall and by post-Taylor X recurrence groups, then we see that regarding the groups 0 to 25 and 26 up to 100, and then overall, as illustrated in the table, that the patients who were indicated for chemotherapy switched to an endocrine treatment alone, had a recurrence score of 0 to 25 in 25%. And so that means the majority of the patients had an indication to endocrine treatment in the low and intermediate risk. And for the patients having a recurrence score of 26 and above, only one patient switched to no chemotherapy. So I think this is consistent from our estimation before. And then from no chemotherapy to chemotherapy, you find the majority of the patients, of course, in the higher recurrence scores from 26 to 100. If you compare the 0 to 25 with the 26 to 100, we have 2.8% versus 56%. So I think this is quite clear and in this way concordant. Next, please. And again, a more precise illustration of the change in treatment, and now according to the nodal status. And the light blue bars are the node negative and node micrometastatic patients, and the dark blue bars are the node positive patients, 1 and up to 3 lymph nodes, as I said. What you can see is a change from chemo to chemo. That means stable indication, patients who were indicated for chemotherapy stayed with chemotherapy. 17% of the patients who were node positive, and 8% of the patients who had node negativity. From chemo to no chemo, 15% of the patients changed from chemo to no chemotherapy in a node negative patient population. And this is really important, I think, a third changed from chemo to no chemo, having a node positive, a nodal positive, so positive nodal status. From no chemotherapy to chemotherapy, this happened only in 7% for the node positive patient population and 15% for the node negative. And then the highest bars we see on the right side, no chemotherapy, stayed with no chemotherapy. That means endocrine therapy indicated, and stayed with endocrine therapy alone. 60% of the patients who had a node negative status, and 40% of the patients having a node positivity. Next, please. And this is quite interesting. And this is, I think, something we of course have to think of, because here you see the comparison from the comparison between the recurrence score result and Ki-67. On the left side, you see the Ki-67 that was central tested, and this looks like a cloud. And one really interesting thing is that the majority, or maybe not the majority, but definitely a cloth, had a Ki-67 central tested below 10%. And think of our inclusion criteria regarding Ki-67 started with 10%. So imagine we had the patients included with a Ki67 below 10% regarding our inclusion criteria. So this is something we cannot tell about. And on the right side, sorry, you see the local Ki67. And if you ask yourself, so why do I see some columns there? Then of course it is dependent on the estimation the pathologists usually do when they don't use an automatic system. That was done on the left side when Ki67 was tested centrally. So 2 pathologists and 1 automatic machine did the central Ki67, and for the reason you see the columns, only pathologists did this estimation. Of course, they do it 5% in 5% steps. So you have columns of 10%, 15%, 20%, and so on. Next, please. So if we want to summarize that, so what was the correlation between recurrence score results and Ki67 and tumor grade about? And we see a very weak correlation to the low Ki67 and not a strong, but a weak, not very weak correlation to central Ki67. And this is really in line what Professor Hartkopf said before, that we don't really have predictive value of Ki67 regarding chemotherapy indication. The correlation between central tumor grade and recurrence score, was in low grade median recurrence score 13 and intermediate grade recurrence score 17 and high grade median recurrence score of 34, just to complete this slide. Next, please. The next slide shows you our rationale where we thought of how do we set our Ki67 range when we designed the study. And as I said, we did it between 10 and 40% because we learned from the Plan B trial that below 10%, and this is something we have to think about right now because of our data, we don't have really a value for recurrence score or an oncotype, and then above 40%, the same situation. But what we learned as well from the Plan B study was that there was not really a really good correlation between central and local pathology. So therefore, this is in line now, or we confirmed with our trial, this low concordancy that was shown in the Plan B study. Next, please. And then something that summarized what I told you before. You see that the REMAR study data in the box, and then you see initial recommendation for endocrine therapy in 68%, and then ended up in 81% of this initial recommendation for an endocrine treatment alone. Only 19% of the patients switched to chemotherapy, and these patients would have had an under-treatment. And this is something what we understand when we talk about individual treatment and more precise treatment, that we avoid under-treatment and over-treatment. And the over-treatment, well, this is really substantial. So 65% of the patients switched from an initial chemotherapy to an endocrine treatment alone. And this is really massive because all these patients would have had an over-treatment, and we could avoid chemotherapy in this patient population. Next, please. This is just an illustration with the illustrations you have seen before. And there you see the spots. So every spot is a patient. You see the potentially undertreated and potentially overtreated patients, just to make it clear by drawing some red lines to show you what happens in this trial, in this data set. And on the right side, you see the same for the local Ki67 testing in comparison or in concordance with the recurrence score result. Next, please. Well, and as I said, so when we planned this registry study, we wanted to really influence, we wanted to force the insurances in Germany, so the payers, to pay for the Oncotype DX test, because we all were really convinced of that we could avoid chemotherapy. And well, we're very happy that time really changed, and you see the landscape in Europe regarding reimbursement of the Oncotype DX test. So this is reimbursed in Ireland, UK, France, Spain, and so on. You see all the different countries. Next one, please. So this is my final slide. Come to my conclusions. Use of the Oncotype DX test has had a significant impact on the initial treatment. I think I made this very clear in patients with hormone receptor positive, HER2 negative early breast cancer. A substantial therapy change was evident in 33.5% of the cases, with an overall 23.5% reduction in chemotherapy recommendations. And this is a real big help for our patients. And the REMAR study confirms, of course, with this data, that Oncotype DX test helps physicians to personalize treatment, to individualize treatment decisions for patients with an uncertain clinic pathological parameters. And this is a real help for our patients avoiding chemotherapy. Yeah, so with my team, I thank you for listening, and I'm really happy to take your questions together with Andreas Hartkopf. Thank you.
Thank you very much indeed. This was really insightful and interesting to see new evidence that we haven't seen before. I already have one question in the chat, and please, this is a call for everybody. Feel free to either speak up or type your question in the chat room. And the first question is, what is the use of Oncotype that is allowed and what is not allowed in general? I think it's not specifically in Germany.
Yeah, regarding the data of the Taylor X study, where only patients with a negative nodal status were recruited. The Oncotype DX test is reimbursed in a node negative situation in patients having a positive hormone receptor, negative HER2 receptor. And we all are waiting for the responder study and the results coming up in San Antonio for node positive patients. And as Andreas Hartkopf showed you, and myself with our REMAR study, we have node positive patients, and I think it's really possible to go for an Oncotype DX test with patients having 1 or up to 3 positive lymph nodes, but it's not reimbursed in Germany, and I think in the rest of Europe as well.
If I may, there are a few countries where it's reimbursed indeed already in a node positive setting based on the evidence already available. Such as Switzerland, they are in Belgium, it's included in Italy as well, so it exists already.
Oh, great, thank you.
There's a question here. Do you think that Oncotype is indicated in PR negative patients?
Is it indicated in PR negative? I didn't see the whole question.
Yes, when PR expression is negative, what do you think?
I don't. So actually, we have some markers or biomarkers where we try to distinguish luminal A from luminal B patient, and the PR status is one of the markers you could use, but it's not very sufficient. So I don't really think that that you can validate or spare patients from chemotherapy by using PR.
Mm-hmm. I have an interesting question, pretty provocative. I don't know where this person is from. Should we not skip Ki-67 completely?
Yeah, so.
Well, this is a really nice question because it's in line what we are living for, because we are living not for immunohistochemistry in the end. Every one of us knows that immunohistochemistry has a variety, and of course, we would love to have genetic results for all of our patients, because we know a gene is on and a gene is off. And so therefore, when we talk about the same question, in fact, my team says, so regarding Ki-67, so this is not really validated, but we have an algorithm and we have such a lot of data for the Oncotype DX test. So this is genetic, and so let's skip Ki-67. So I understand your question indeed, yeah, but I think Ki-67 is really useful in a combination. And this is some data that will be presented in San Antonio from Germany, from the VSG study group, the ADAPT main phase trial, where we see what happened in the POETIC trial and the IMPACT trial, that you can use Ki67 as a window of opportunity parameter for 3 weeks endocrine treatment, and then you measure the Ki67 drop or increase. So this is something very useful. But yeah, your question has to be answered in the future. And I think it's a really good one. I cannot answer it right now.
How would you address it, Professor Hartkopf?
I would agree with Mark Thill. I think the dynamic measurement of Ki67 when you use endocrine therapy is interesting, and is something that might be something that we will use in the clinical practice. But the thing, what remains is that if you use Ki67, the problem is still that you have those different results by different pathologists, and if you use it as a single as a single marker from one time point, there is no prospective trial that shows you that you can that it really helps to guide you through chemotherapy decisions, so that it's actually predictive of chemotherapy.
Okay, thank you very much. Really an interesting discussion, and I think even more interesting coming from physicians from Germany, where Ki67 was developed to start with. So I thank you for sharing your views here. There are a lot of questions and comments in the chat, so I'll try to take them as they come. So it might be different topics. I have somebody from Brazil who say, here in Brazil, our oncologists always argue against using Oncotype in younger node-positive patients. What are your thoughts?
So I wouldn't argue against it. We have seen those data where Oncotype DX was used in younger patients, and you should use other cutoff values. But I would not agree with to not use it in younger patients, because the next question would be where's the cutoff age, when to use it and when to use it not. And when it comes to node positive patients, I think we will see in the responder trial that you might need cutoff values for using chemotherapy or not in different age groups, so different cutoff values, as we see it in node negative patients. They might be around 20 or something, but I will think we will see some data where we have distinct cutoff values for distinct age groups, even in node positive patients. So I think we can use it and in the future we will have more data how to use it.
And I mean, in younger patients, we have a higher proliferation anyway. So the Oncotype DX is based on proliferation. The Ki67 is proliferation. So therefore, you will get a higher recurrence score results anyway if you have a higher proliferation. So therefore, don't be frightened of having the situation that you have a node positive young patient. This is our situation. For the reason that it's not reimbursed in Germany, we don't go for a node positive young patient anyway.
And one strong component of the estrogen, the whole estrogen group in the Oncotype DX, and we've seen that in a recent publication from Transattack looking at the characteristics of the assay. So you're right that proliferation is there. I think it's not that black and white, right? It's really multigenic from that perspective.
And then there's another thing when it comes to node positivity. Those patients that node positive patients, they do have a worse prognosis as compared to node negative patients, but it's not the nodal state does not tell you if chemotherapy will work. So, and I think that's why the responder trial are so important to see, because I think the most interesting subgroup to use the oncotypes are actually the node positive patients.
Yeah, so this is a good point regarding when we think of neoadjuvant chemotherapy, Andreas, what we do in Germany very frequently, that especially luminal B tumors, you don't have really this effect of chemotherapy. And when I think of the meta-analysis of Lara Spring, we have a delta between non-PCR and PCR and triple negative for 30%, 25% in HER2, only 9% luminal B. So therefore, these patients need some other treatment, endocrine treatment, not only chemotherapy. So I would agree on that with you.
I'm not sure we will have time to address all the questions. There is one here. Would you test a patient with a PT1 tumor for a Ki67 or 70%?
No.
No.
No, I don't think so. So a Kia 70%. So with our experience, so we did, let me think, we did in my department right now more than 400 or 500 Oncotype DX tests. And from our experience, if you have a 70% Kia 67, you will have a high recurrence score. So therefore, I would skip that.
Yeah, there's but one thing where I might use it if you have. Sometimes we see, but not with 70. That's actually, you are right. With 70, it's so high. If you have a high Ki67 but a low grading, then I would go and look for another tool, which would be Oncotype.
Yeah.
Mm-hmm. Okay. Interesting question here. If we have a HER2 negativity by FISH, but the results of Oncotype, sorry. Would it affect the result of Oncotype in comparison to a HER2 negative by IHC? I don't know that this has been studied really in that.
No, we don't have data for it. And when I can compare it with some other multi-gene assay studies we did, I remember the PRIME study. So there was a study where we used the Prosigna test, but only the classifier. And in the classifier, sometimes we had an EHC hormone receptor positive patient, and then molecular we had a triple negative patient, and we have no data for it. So therefore, whether in this situation or any other situation, so regarding the questions, no data. So therefore, it is not an influencing factor.
Mm-hmm. I would tend to agree with you. There are a lot of questions on positive patients. I want to come back to a patient case here. We have a case with a DCIS mass with microscopic foci of ductal carcinoma, less than 5%. Do you recommend testing with Oncotype in this case? Less than 5%.
With micro of invasive less than 5%.
So I would say, so this is very difficult because it depends on the size of the DCIS. So then you really have to have a good pathologist. If you have a DCIS, let's say of 8 centimeters, for example, and then you have found one focus, and maybe you have different other focus, and then it's a relation. I'm not a pathologist, but it's a relation between the DCIS and the foci you find. And if you have enough foci, yes, why not? Because then you have cancer, and then you go for an Oncotype DX. But it's a matter of relation in the end.
I have two questions here that are related to each other. One is, what do you do when you have multicentric tumors? Do you test both of the tumors? Or the other question in the same direction somewhat is, when you have a large tumor heterogeneity and the possibility of having different results with, if there are morphological difference within different areas of the tumor. So how would you address in this case?
So there is the answer in the question, or was it? I don't know if it was two questions. So if you have a multicentric or bicentric tumor, and if the pathologist tells you one is grade 1 and one is grade 3, or one is Ki67 low and the other is high, then I would use the Oncotype, at least in the foci that seems more aggressive. I wouldn't even use it in both. I would just choose the one that looks more aggressive for the pathologist. Mm-hmm. But if the tumor is the same, it doesn't matter. I wouldn't use more than one test to to check for every lesion in the breast.
Yeah, I agree.
I can confirm our lab, this is how our lab would proceed. We would always test the tumor that looks the most aggressive based on pathology. And if the recurrence score is high, you're going to treat anyway with chemotherapy. So there's no point of testing the second one. I think we're really running out of time. We're already over. There are a lot of questions. We're going to try to capture them and get back to you. I see there's one burning question. Maybe we address that one as last, which is for node positive patients with a T3, so relatively larger tumor. Would you still rely on Oncotype for chemo decisions? What would you think? Are we waiting for San Antonio, or do you have an opinion already now?
I think I know what is going to happen in San Antonio.
So in fact, we could, as we are able to recruit patients for the ADAPT cycle study, and I was just discussing about one of such a case today. And in the ADAPT cycle study, it was low risk, and we go for low risk. But this is in a study, and this is not daily routine. So we wait for San Antonio.
I think it's a really nice way to conclude. First of all, I want to thank you very sincerely. This was a great discussion. A lot of questions on really reflects how interesting the data you shared are. A lot of questions on positive, and indeed, there will be a lecture on RxPonder at San Antonio on December 10th. So we're all looking forward, hopefully, to meet again after San Antonio so we can discuss this. Thank you very much, Professor Hartkopf and Professor Thill, and to the audience as well.